Welcome everybody. This is our latest update to the community of interest on our cancer study for our missile community folks. Again, we'll get through the update and then we'll open it up for Q&A. And then, like we've said in the past, if you don't have the opportunity to ask a question, we can submit it through the portal too. So, Greg, are you going to start it?
Yes, sir.
Okay, fire when ready.
Thank you, sir. Good afternoon, everyone. I'm Colonel Greg Coleman, Command Sergeant, Air Force Global Strike Command. I want to thank you all for joining us today as we share another significant milestone in the missile community cancer study. For more than 2 years, we've remained steadfast in our commitment to transparency and safety in the missile community. We can go to the next slide. Today's town hall is a continuation of that commitment. This town hall will focus on the understanding of the current environment at the 3 missile wings and how it relates to the institutional processes that we've developed to communicate potential risk to airmen and their families. So along with the missile community cancer study objectives on the screen, following those first 2 objectives from left to right.
So Greg, let me just voice over here for a second. So these are the primary pillars and objectives for the study that we started 2 years ago. We have had a couple dovetailed excursions from this original these original pillars. They all fall within it, but we get additional information as time goes on from different members, and we add them into these pillars. This is kind of the initial framework we had to make sure we didn't miss anything on the current environment. And then understanding the risk over time, and then making sure we have the institutional processes in place to account for exposures or other incidences across the fabric of time for airmen that are either separated, retired, or no longer serving. So that's kind of the big rocks haven't changed, but we've had excursions within those pillars when we get additional information.
Sure. Today, we'll share a lot of data related to the comprehensive health risk assessment, but more important than the data is our commitment to ensuring a safe environment through continued monitoring and assessing of the community beyond the study itself. You can go to the next slide. So this will serve as a recap of the timeline that we've had over the last 2 years. And the cancer study focuses not only on the question posed in December of 22, do missilers have an increased cancer risk, but the study also seeks to understand any potential exposures to hazards that may exist in the work centers for our community. To address both of those elements, the missile community cancer study was divided into 2 main lines of effort: the epidemiology review and the environmental sampling effort. And this occurred after initial site visits in the March and May timeframe. On the epidemiology review, it compares to 14 common cancers in our general population with those in the missile-related career fields. The review looks at the incidence rates of cancer, and it requires an analysis of specific data sets to ensure we are not only addressing those who currently serve, but those who served at one time in the missile fields across our nation. The environmental sampling effort was divided into 3 seasonal rounds of sampling the air, water, soil, and radon to ensure a safe environment for our missile community. The environmental sampling is now complete with over 8,400 samples collected and 100,000 data points. The School of Aerospace Medicine has developed a comprehensive risk assessment to help us better understand any potential hazards in our environment. But even before our sampling efforts began, changes were made to ensure that safe environment. For example, our parking signage was updated to mitigate any exhaust fumes from vehicles entering the missile alert facilities. RF signage was updated, as well as ceasing all burning activities in our launch control centers. During that first round of sampling, and consistent with prioritizing safety and transparency, environmental sampling found 4 of 900 polychlorinated biphenyl swipes that were detected above the recommended EPA threshold, and about 90 EPCB air samples that were non-detect. The missile alert facilities were immediately closed, and they were cleaned and mitigated before allowing any airmen to return to those facilities. So throughout 2023 and 2024, the spring of 24, environmental sampling of air, water, soil, and radon continued to assess for seasonal variation and also expanded that look to include Vandenberg Space Force Base and Hill Air Force Base. During that same time frame, we released phase 1 of the epidemiology review, which looked at the military electronic health record data, and that limited data set found no increased risk of non-Hodgkin's lymphoma, but a potential trend towards an increase in breast and prostate cancer. The expanded but still incomplete phase 1B did not identify any elevated incidence of non-Hodgkin lymphoma or any of the 13 other individual cancers in the study. Earlier this year, we presented the phase 1 Charlie of the epidemiology review, and that did not identify any statistically elevated mortality within the missile community when compared against the US general population. We will complete the phase 2 of the epidemiology review later this year, and that is a virtual pool registries, including all the state registries from around the nation. In addition to the epidemiology review led by USAF-SAM, we are aware of a study that was published by the Torchlight Initiative. While this study is separate from the missile community cancer study, it does add to the work, advocacy, and the well-being of the missile community. That covers a brief summary on how the study has progressed over the last 2 years plus, and we'll now hear some of the ongoing actions in the missile alert facility to ensure a safe operational environment. Next slide.
Good afternoon, sir. From the A4 side, the PCB response protocols are standardized across all of our technical orders, civil engineering manuals. We validated that the signage warning technicians and operators of the potential for PCB presence in specific locations has been properly applied. And we've gone one step further with that, and we're including it in our periodic maintenance inspections to validate that the signage remains current and it doesn't disappear over time. On the missile alert facility environmental control systems, we're in the final stages of publishing and implementing some advanced, increased cleaning procedures for intake and exhaust ducts and CBR filters to make sure we're providing the cleanest air possible in the LCCs. We're in the final technical procedure review for our depot level technicians and validating parts supportability so we can implement with 100% accuracy. Our 836 brothers have validated that we have cleaning contracts in process across all 3 wings for the hygiene side of an annual cleaning. And our PCB cleaning contract, which is a separate effort, is underway right now. 3 LCCs have been cleaned. The 4th LCC is scheduled to begin 9 June. And
Is that the same contract or is that a different?
No, sir, it's 2 totally separate
No,
efforts.
I'm saying the PCB cleaning contract, is it one contract for all our units?
Yes, it is.
Okay. Okay.
It's actually a multi-year contract with one company that's
Okay.
going across all 3 of our wings. So we're getting a standard level of service
Okay.
at every LCC. The PCB sampling for launch facilities is integrated into our annual inspection processes.
Okay.
Any of your questions, sir? That's
Thank
all I have.
Go to the next slide. All right.
Good afternoon, sir. This slide is a reminder of the 3 rounds of sampling that only represents the current sampled environment. It did not and cannot measure the past. This environment was sampled in 2023 and 2024. The sampling was designed to cover seasonal variations and potential environmental hazards based out of discussions between Global Strike Command, the missile alert community, and USAF-SAM. We did not find any seasonal variations. In fact, we did not detect most of the chemicals for which we sampled. On the first round of the results, we communicated the presence of surface PCBs. This has already been communicated, and as mentioned, Global Strike Command is actively mitigating this hazard. Of note, this environmental sampling strategy was never attempted before. The missile alert facilities were previously not tracked as an industrial workplace. If I can go to the next slide.
So for Rick or for Greg here, remind me again on the unit level public health access and authorities for our maps,
Refer to
the teams.
the occupational
Yeah.
cases. We developed the occupational shops, right, to allow for any potential hazards or exposures to be documented into the DOORS system. And then that feeds directly into their medical records. That also communicates to the individual longitudinal exposure record that the VA has access to, as well as we do. So any of the 100,000 data points that were collected during the sampling portion have already been added into the DOORS system on the environmental health side. And we've set up occupational shops for all of the MAFs and the MAF personnel so that their potential exposures or anything that occurs is documented in that system, and that is part of their medical record ongoing.
Okay. Thanks, Rick. Sorry to interrupt.
Bring you the next slide. So let's talk about what these environmental results mean to health. The United States Environmental Protection Agency has a structured process to evaluate these environmental samples, and that process is called the Health Risk Assessment. You'll see that as HRA. There are 4 steps outlined by the Environmental Protection Agency on how to conduct this type of assessment. This methodology was also endorsed with our partnership along with the National Institute of Occupational Safety and Health. Thus, we have an environmental strategy being endorsed by an occupational expert. This health risk assessment applies a framework tool to present this information. Briefly, the 4 steps start with hazard identification. Hazard identification is a process where we identify which health problems are potentially caused by the chemical. In other words, the hazard is the health effect the risk assessment is trying to characterize. For example, a total cancer risk is the hazard we were evaluating for. It is not the environmental chemical that an individual is inhaling, ingesting, or absorbing. The dose response merges the hazard, such as looking for cancer, with the environmental exposure. For example, EPA has cancer curves that correlate 70-year environmental exposures to the risk of developing cancer. However, not every chemical has human data, and some data is extrapolated from animal models. Most cancer curves are based on a lifetime of exposure. The exposure assessment is the methodology of collecting the samples. This data has already been reported and released to the community previously. The risk characterization is the integration of the environmental sampling with the dose response curves. As mentioned, this framework highlights the 3 exposure routes, including inhalation, ingestion, and absorption, and are added together. This assessment has 2 main components, a total risk and a non-cancer risk. Any questions? Move to the next slide. A few more details on how this health risk assessment was completed. Again, this was informed by consultation with NIOSH. If any chemical was detected at any level, then that chemical was included in the health risk assessment for that base. Stated differently, if a chemical was not detected in any sample of any round, then it was not included in this health risk assessment. The statistical estimation was calculated by the Air Force Institute of Technology, AFIT, their Scientific Test and Analysis Technique Center of Excellence, known as STATCO, to provide a single value that represents all the detected values with a greater than 95% confidence. For example, if a base had 90 separate samples across all 3 rounds at all of their MAFs, then, which is an example, then 86 of them were not detected, but only 4 were detected and had values. That is a skewed data set that requires more in-depth statistical analysis than simply an average. Dose-response relationships are limited by existing data. Most of the carcinogen data is from the EPA that assumes a lifetime or 70 years of continuous exposure. We acknowledge that the length of that exposure would be well in excess of any individual that would be working inside our missile alert facilities. However, it is also the most conservative way to assess the possible risk. But we also understand that is not an accurate example from what we know from career data. Another time perspective that we will use in this study is 8 years, or briefly 2 standard tours inside a MAF. We will use this time frame later throughout this discussion. The threshold of risk reported in this health risk assessment is that at least 1 person per 10,000 exposed. That cutoff is in accordance with the 2017 NIOSH bulletin that frames this denominator of workers. Pending your questions, the next slide. Of the detected chemicals in this study, this slide informs how we defined what a carcinogen was. First, we followed the Agency of Toxic Substances and Disease Registry for guidance. The ATSDR recommends the following 4 databases to classify cancer risk. In addition to those 4 databases, we also referenced the American Conference of Governmental Industrial Hygienists. We believe this provided the most conservative estimate, using 5 databases that we used to identify chemicals that were considered to be capable of increasing cancer risk. Not all 5 databases have evaluated every single chemical. We classified a chemical as a carcinogen if any one database suggested there was a cancer link. In each of the health risk assessments, there is a specific appendix in each report that it reports out this matrix for each detected chemical at every base. As a baseline reference, the American Cancer Society recently described the population of risk of developing cancer. Males in the United States have a lifetime risk of developing cancer of 39.9%, and females have a 39% chance of developing cancer. This is 3,990 per 10,000 males or 3,900 per 10,000 females. Next chart. The first component of this health risk assessment is the total cancer risk determination. This measurement adds all 3 routes of inhalation, ingestion, and contact absorption from each of the carcinogens that were detected using the statistical estimated value. We are presenting this data as a range, with the lower and higher end numbers that represent bookends for the total cancer risk based on the results of this environmental sampling. The lower bound estimate is based on an 8-year of exposure, while the conservative upper bound estimate is based on a 70-year exposure. The 8-year exposure is consistent with a career pathway of a 13 November missile operations officer as provided to us by Global Strike Command. The lower bound of this range is less than 1 excess cancer per 10,000. In other words, it is comparable to the US general population. This is true for all 3 bases. The total risk cancer determination for the missile alert facilities of the 3 active bases are as follows. For Malmstrom, less than 1 to 23 excess cancer cases per 10,000 persons. The less than 1 value represents the 8-year exposure, while the 23 represents a 70-year exposure. Restated with US cancer rates, an increase of cancer rates in males moves from 39.9% to a range of 39.9 to 40.13%, and from females, 39% to a range of 39 to 39.23%. F.E. Warren, less than 1 to 11 persons. Again, restated with US cancer background, this rate moves males from 39.9 to a range of 39.9 to 40.01, and females from 39 even to a range of 39 to 39.11%. Minot, less than 1 to 7 excess cancer cases in 10,000 persons. This represents by a shift, again, male cancer rate from 39.9% to a range of 39.9% to 39.97%, and females from 39 to a range of 39 to 39.07%. The executive summary in each of these installations' health risk assessments communicates these values as a total cancer risk range. This cancer risk is not specific to any type of cancer. On the next slide, I will walk through the cancer risk analysis for Malmstrom. Looking at Malmstrom Air Force Base Missile Alert Facility cancer risk, we are demonstrating with full transparency these charts. The top 4 rows represent the detected chemicals that were found in air sampling, those that are inhaled. The inhaled cancer risk on this slide represents a lifetime or 70-year exposure from the statistical level found in our rounds of sampling. Ingestion and absorption follow next. Just to walk through the top line of this chart, benzene is considered a carcinogen. A statistical estimate applied to a 70-year exposure results in 17.9 cancers per 10,000. The total inhalation cancer risk is assessed to be 22.3 cancers per 10,000, and then the total risk for the lifetime exposure in a Malmstrom Missile Alert Facility is 23.4 cancers per 10,000. This slide represents the cumulative lifetime exposure. For comparison or contrast, the 8-year, again, two full term assignments, that exposure at this location, that total cumulative rates, again for 8 years, is less than 1 per 10,000. This is true of all 3 locations. Of note, benzene was identified in this health risk assessment. Of the 270 samples from all 3 bases and rounds that were completed, it was detected just 16 times, 8 times at Malmstrom, 4 at FE Warren, and 4 at Minot. In reviewing this specific chart that exists for all 3 specific bases, benzene was the largest contributor to the cancer risk of a lifetime exposure in our assessment. Benzene is found in cigarettes, cigarette smoke, vehicle exhaust, and gasoline. Pending questions, move to the next slide. Switching to the second component of this health risk assessment, the process that characterizes the non-cancerous health concerns. Just as cancer health risk assessment has 2 bookends, the non-cancer one does as well. For non-cancer, the higher bookend, which is akin to screening for a lifetime exposure, we called it the health screening value. For this value, we looked at different organizations that publish screening values to evaluate for non-cancer risks that are listed in order of priority. When a federal screening value was available, we used that one. For example, Title 40 of the Code of Federal Regulations, followed by the Agency of Toxic Substances and Disease Registry, the Department of Energy, etc. In the absence of a federal screening value, the most conservative state screening values were utilized, followed by military values and then international. These screening values are designed to detect lifetime exposures and are commonly much smaller than the federally regulated action levels. For each chemical, we considered the risk of simultaneous exposure through all routes and the impact it would have on multiple organs. For example, if we consider benzene alone, it can impact 8 different organ systems as outlined in the Agency for Toxic Substances and Disease Registry. Next slide. The non-cancer risk methodology uses a hazard quotient as described in the middle of this chart. The statistical base exposure from StatCode's 95% confidence estimation of our detected samples is the numerator. The lower bound levels were derived from federally regulated action limits. Again, as we previously stated, there was no single level that exceeded an action level noted except for the presence of PCBs, which we've already talked about. The framework demonstrates the plausibility of simultaneous effects from all of these chemicals. The health screening values were calculated from a lifetime exposure to the health screening value was calculated from a lifetime exposure down to an 8-year exposure at a given missile alert facility. As mentioned before, the health screening value is a smaller number than the regulatory limit. Hazard quotients will be smaller for federal limits, and the health screening value will be larger, and this will give us our 2 bookends of this assessment. The lower bound reflects limits set by regulations requiring action, so it's essentially what's legally required for us to act upon. The upper bound is more conservative. It uses the most protective health screening value available. Adding the hazard quotients of the 3 exposures together gives us a total hazard quotient. If that number is less than 1, we interpret the exposure as acceptable. It's under the level expected to cause harm. But if the number is greater than 1, it doesn't necessarily mean harm is occurring, but it does mean that further investigation may be warranted. This number, if greater than 1, does not imply an increased severity or probability. There is no relationship between 1.1, 3, 5, or 10. The methodology only considers if greater than 1. If the hazard quotient is greater than 1, then an organ analysis would then need to be completed. For every organ system, and there are 13 of them, like lungs, kidneys, or skins, the hazard quotient was added together for every respective chemical. In terms of the 13 organ systems that had a hazard quotient greater than 1, the results of this health risk assessment for non-cancer risk is as follows. Malmstrom, with a lower bound number of organ systems, is 1, and that was the organ system of skin, to an upper bound of 11 organ systems. FE Warren had a lower bound number of organ systems of 0 to an upper bound of 11 organ systems. Minot had a lower bound number of organ systems of 0 to an upper bound upper bound of 1 organ system, which was skin. I will explain more of this while we look at an example from Malmstrom. Next slide. This is showing each chemical in the left column and the target organs along the top. Highlighted in yellow at the bottom is the corresponding calculated hazard quotient based on the health screening values. Again, this is the upper bookend to take into consideration. 11 of these values are above 1. Again, this doesn't necessarily mean harm is occurring, but it does mean that further investigation may be warranted. The magnitude of this number of greater than 1 does not indicate severity or probability. It is only interpreted to direct further evaluation. In contrast, I like to compare this upper bound to the lower bound, which is the federal regulations requiring action, and that'll be present on the next slide. If we take the same information applied to the federal regulation action limits seen in the third column, you will see the cumulative organ hazard quotient on the bottom row. Specifically, for the lower bound, Malmstrom was the only base that had an organ system above 1. This is primarily because Malmstrom had 2 different PCBs detected. F.E. Warren and Minot did have a PCB, but it was a singular type. This explains why the additive nature of this methodology assesses Malmstrom with skin being above 1, and the 2 bases did not have any organ systems with a cumulative hazard quotient exceeding 1 at the lower bound. In summary, this health risk assessment provides us with a total cancer and non-cancer impacts. We describe the exposures both from an 8-year exposure and federally action requirements to a lifetime of exposure and screening aspect. These ranges are consistent with an occupational shift work focus and a lifetime environmental exposure concern. Members that work in a missile alert facility fall somewhere between the shift worker and the lifetime exposure. As a result, this health risk assessment based on the current environmental sampling confirms the action that we have completed by standing up missile alert facility occupational shops. What does it mean to be in an occupational shop? Number 1, bioenvironmental engineers will regularly sample and evaluate for the identified exposures and further characterize this risk. This is an iterative screening process that will identify the sources of the health hazards until they are eliminated or mitigated. These results are reviewed regularly by the Chief of Aerospace Medicine as part of an occupational working group. Any new results are reported back to the shops and their supervisors. Number 2, public health will guide supervisors in hazard communication for the workplace exposure. Documentation of this exposure will now become an OSHA requirement as long as members are in the corresponding shop. Shop supervisors will be required to maintain accurate rosters to track the community that works inside these missile alert facilities. Number 4, the accurate rosters will ensure the occupational and environmental health exposure data sheets, you will hear that often known as OEHEADs, will be added to every member's health record. An OEHEAD has the list of the exposures and the hazard communication. OEHEADs communicate the chemicals and processes that increase health risk. We foresee increased communication between bioenvironmental engineers, public health, flight surgeons, and the workers to explore when and where these chemicals are present in the workplace and how to mitigate these hazards. In summary, this health risk assessment characterized the health risk as low, but not 0. Therefore, the appropriate action is to include missile alert facility workers in an occupational surveillance. Standing by for questions.
Great update, Rick, and again, exquisite health assessment with the data. So thanks to you and the team for doing that. Greg, over to you for the way forward.
Yes, sir. So the health risk assessment continues to build on the institutionalized processes that we have in place and have identified workplace hazards and potential exposures. This all gets documented in the DOORS system that feeds directly into EILER. That connection happens every 4 hours. It feeds from DOORS to EILER, and it takes about 420 milliseconds to occur. So that is occurring now. What we are working with the EILER team to continue to do is to grant you individual access. The team is beta testing now. They will expand that beta test in July. And we would like to see at least a presentation of what that looks like in October for the individual access with the full deployment scheduled for December of 2025. We're continuing to explore the burning of classified materials, working with with A3 on the processes of how and AFRL will conduct that burning of classified materials look for us later this summer, again, with expectations that we'll have additional details out to share in the fall. As previously mentioned, the phase 2 of the epidemiology study continues as we gain additional information from the civilian cancer registries. Of note, right now we have more than twice the number of cases garnered from the state registries than we found during phases 1A and 1 Bravo. So about 117,000 cases have come in from the state registries. All that data must be first deconflicted, and then we can conduct the additional analysis for phase 2 with the projected completion for 2025. We continue to partner with the VA. We recently shared information through Vet Resources and their outreach program with veterans on the status of the Missile Community Cancer Study, and provide an update to the VA's Military Environmental Exposure Subcouncil. At the end of our study, the VA has come on board to continue to follow this cohort within their system. And so while we may come to some level of conclusion with the study itself, it will continue to be monitored long-term through the VA. And you continue to reach out and use the resources that are there. We have the QR code on the screen for you to ask questions back to us, and we can respond to you through your personal email or visit our website where we have all of the data that we presented in the past, reports, town halls, and Q&A, frequently asked questions. So that concludes this portion of the brief.
Thanks. Lauren, you want to open up the questions?
Love to, sir. 1 second, let me pull up the chat. Okay, we have one from a former facility manager at FE Warren, who was there for 5 years with 2 different squadrons. Is there anything that he or others like him need to be concerned about or to be on the lookout for in the coming years? And specifically, what does the health risk assessment mean for me?
Speaker, you want to?
Yeah, I think that's a great question. And so when I think of this health risk assessment, working for someplace for 5 years, we used 8 years as a starting point, and there's a somewhat linear response between this time. And so the likelihood and our understanding of this health risk assessment for somebody that worked in a missile alert facility is under a concern that raises your risk for cancer, anything above the United States baseline. We do not see any increased risk with working in a missile alert facility with a 5-year exposure.
So I get the only thing I'll add to that, we're just chatting, is that I think maybe the basics of the question have to do with, is this data going to be applicable to a facility manager? And I would have to say yes. So the critical AFSCs we looked at, the facility manager is kind of a one-off because of the special duty, but we'll take that for action to make sure the report at least captures the different AFSCs and exposure for folks that are in the MAF/LCC area. So that makes perfect sense. But from a macro perspective, short answer is the data would apply to your specialty. Over.
Okay, on to the next question. And I'm going to present the question up front and a little bit of background on the back. Are there PFAS, PFOA studies underway with respect to this study? The background is we researched and found that PFAS, PFOA, AFFF is no longer used at Malmstrom, and all use was discontinued in 2018, and that fire trucks and any facility fire suppression systems that formerly used AFFF were purged and triple rinsed to ensure no contamination or leakage. However, was there anything that was involved in this study to look at PFAS, PFOA?
No, there wasn't. So that chemical and that exposure and that risk that the department's identified over time is not part of this study. I can't speak to whether there's another study in the Department of Defense that covers that or not, but this study does not include that.
Thank you, sir. The next question, does this missile cancer study address those of us who served in Titan or Atlas? And if not, what has the Air Force done to study cancer in Titan and Atlas crew and maintenance personnel?
Not a new question. We've covered this in our previous forums. It's actually it's not an uncommon question from a lot of our prior service members. So it doesn't. We can make some associations of our study in the current Minuteman III field in our 3 wings. There might be some correlation back to the old Titan or Peacekeepers, but we don't obviously have those systems anymore. So making a direct correlation may not be capable, but we were trying to do a historical poll and find out what chemicals or carcinogens were at least identified in the old tech orders so that we could have some sort of connection to the previous weapon systems. Does anybody have anything to add to that?
So General, I would add that as part of, although not included in the environmental assessment, all going back to 1976 and coming forward, if you were in the missile community, writ large, you're part of the epidemiology review. So we will see incidence rates of cancer that may have be associated with that community prior.
Yeah, good point. So the cancer data poll goes all right back to the 70s. But from a practical standpoint of testing or understanding what exposures were in those previous weapon systems, this study can't account for that other than potentially some historical reference points.
Next question, sir. We're using data sets from the early 70s through present day, but are there any ways to provide results through a specific period of time? The example given was at Malmstrom from the period of 1990 through 2005, but is there a way to specifically analyze time periods where people might have been present at those bases? Or is this an all-encompassing study? Over.
It sounds like, Lauren, that the question was, can we carve out a certain year group at one base out of the data? Is that kind of how you read the question?
Yes, sir.
I'll defer to Rick or Greg.
Yeah, I got the nod. Yes, sir. So I think part of the epidemiology study comes down to a concern of power. And so the more data, the more numbers of cancer that come in from the virtual pooled registries provide more numbers for the statistical analysis to be done. So the more cancer cases that we have allows us to actually, I use the term slice and dice because I look at a base, kind of look in decades. Those are the levels of concerns we're looking for. But if you start coming down and only 2 or 3 cancers were in that time frame, it's hard to make a viable assessment when the numbers are really small. You need a larger number for the statistics to prove that there is something there or is not something there. And so it comes down to a power of how small those smaller segments are.
That makes sense, but when the study's done, will the database allow sortability and kind of framing to kind of go through the data in that realm?
We are planning on, and it's hard because I need the data set to see what's available, but we will demonstrate what we did, how we bend. We tried to bend it. We could not get to that smaller level. We will say what we tried to do, and we'll demonstrate what we did do.
Okay, thanks.
On to the next question, sir. Considering that USAF-SAM is conducting the study or research, is there an independent agency also auditing the results of the study or the research?
So I'll take that one. That's a great question. And so we worked very closely with NIOSH, so Wright State University and Rutgers University. In fact, we had a Rutgers assistant professor that gave us great feedback and was very complimentary of what we provided. And so we believe using both inside USAF-SAM, going outside USAF-SAM through AFRL, other parts inside AFMC, to include other non-federal academic partners and federal OSHA workplace specialists. We believe that we provided a great third-party review of what we did and presented today.
Yeah, that's not a new question. It's a real good question. It was something that, quite frankly, the secretary of question that.
Hey, sir, really quickly, you're coming in kind of muffled on your end. Try again, sir.
Okay, I said, that's a good question. It's not a new question. We've had it in previous forums. Previous Secretary of the Air Force directed that the study also include along the way independent peer inputs, as well as when the study's done, we'll have peer reviews. Over.
Okay, a little bit better, but there's still something muffled going on in there. Let me see. Colonel Speakman, could you take the next question first, and then, sir, we'll try to get in and figure out what's going on with the speaker in the conference room. But Colonel Speakman, sir, how are we mitigating the risk from toxins detected to reduce or eliminate cumulative or compounded exposure over an operator or maintainer's career?
Yeah, no, that's a great question. If I just read it back, it's how are we actively going to be mitigating these toxic concerns that might an operator or anybody that's working in a MAF be exposed to? And this is what really the understanding of hazards of controls, hierarchy of controls talk about when we think of what does it mean to be in an occupational workplace monitoring system. And that issue is very iterative, which will involve more of bioenvironmental engineering. We'll be coming around and asking more specific questions and monitoring along people and what they do throughout entire work shifts. This initial study was more of a broad swipe, what's in the environment. As we move forward, it will move from more of a generic environmental sampling down to a what does a worker expose through as they move through their day. And so as we further characterize where these chemicals are coming from, where is it at, and we further understand the chemical exposure to the workplace process, that allows us to understand how we can actually understand the engineering and elimination and administrative controls that will allow us to further protect the workforce.
General Bussier, anything else to add, sir?
Thank you.
Okay, on to question 6. Were the 564th Missile Squadron capsules sampled?
No.
Okay, what is the status of the study for maintainers working out at our remote launch facilities?
The maintainers should be included in the data. The way I understand it, the study includes missile areas, food services, or the missile shops, the maintainers. It's everything associated. There's not a separate study for the maintainers. The maintainers are included in the overall effort.
And then talk to the LF sampling.
So the LF sampling, we started with one LF per flight in each one of our operational squadrons, and we're kind of rolling that across time, where we're doing a sample size each year for launch facilities. So we're continuing testing program for the launch facilities.
And I would add as well, so our maintainers and launch facility maintainers were already involved or already in an occupational shop. So the missile alert facilities were not considered an occupational shop until we started the process of doing this study, but the maintainers had always been a part, had always been part of there. So they have documentation indoors, part of their medical record and part of their examination. So that already exists where it didn't exist for the missile alert facility. facilities prior to.
So the data analysis includes maintainers, and then we are sampling the launch facilities and the equipment rooms.
And to kind of Coleman's point, you know, the maintainers, the awareness of PCBs has been there for decades.
Okay, on to the next question. Is the documentation of missile duty going into medical records only for current missile crew systems, or is it retroactively being done for all missileers?
There's not a way for us to do it retroactively into the system, so as we establish the shops through 2024 and going forward, everyone who joins the missile community coming in will be included in the as part of their occupational shop as standard work at this point going forward. Unfortunately, retroactively, we cannot go back in time to add people to those shops. So a couple of things that we've done previously. Over a year or so ago, we published a PCB letter that encompassed our known presence of PCBs going back to the Titan missile weapon system and coming forward, and that memo is available on the website and also identifies locations of where we had missile weapon systems across the U.S. So that's one piece. The other piece is if you're still serving and as you're having your one-on-one conversation with your PCNs, we encourage that conversation to get some documentation in your medical record. And as you're doing your separation health and physical exam, another opportunity to ensure that your service in the missile community is well documented in your medical record as you either separate or retire.
So for folks that are no longer serving, that aren't in the current career field, the memos are on our website, and then you can take that memo and either use that with your PCM or with the VA providers to get that into the system. Is that checked?
Yes, sir.
Okay.
The next question is the missile community that was studied homogeneous with respect to cancer exposure and risk factors? How do maintainers versus food service personnel's exposure differ?
I don't think it's to that level of detail in the sense that, you know, a missile, a MAF chef versus a facility manager versus a maintainer versus a operator is the data and exposures kind of encapsulates all those AFSCs that have access to or exposure to what we've discovered in that workplace. So there won't be like a missile or facility chef has this level of exposure, and an operator has this exposure. Really, it's a blanket level of understanding, fully acknowledging that the exposure may be different, but we don't have that level of fidelity in the study. Does that check with you and Rick? Okay.
Okay, and can we confirm the study only confirms the defined missile community cohort is not statistically higher than the general communities?
If we can address that from the EPI side.
Say again, sir?
Your question?
Can we confirm the study only confirms the defined missile community cohort is not statistically higher than the general communities?
I think what we know right now in terms of, and I'll defer to Youssef Sam in a second, but as what we've looked at in the phase 1 alpha and phase 1 bravo with the epidemiology study, we have not seen that the number of expected cases for the missile community cohort exceeds those of the U.S. general population. Youssef Sam, is that?
I'd like to continue on that. When you say different population and cohort, that's the epidemiological study, At phase alpha, 1 Bravo, we have not demonstrated a difference between the cohort and the US population. When we're talking about today is basically more of an environmental concern. What does an exposure of the carcinogens at a low level that exist in the map, could those be attributable to a cancer with a really long exposure? And that answer is yes. The 70-year exposure, with example of benzene in Malmstrom, 70 years exposure, that's around 18 out of 10,000 would have an attributable cancer from that level. That is not a cohort. That is just because of the environmental exposure. It's not a cohort looking at two different groups of people. And so I know that's very scientific, but the epidemiological study is the one that compares two groups of people. This today says, is there a concern from an environmental exposure that can attribute, because of that environmental exposure, to an increased cancer risk? That's not actually comparing any one different group of people.
Yes, just to expand upon that, I know you've said it a couple of times, but just to be clear for the folks that are listening, is 1 Alpha and 1 Bravo, it was about 50% of the data, give or take.
Roughly.
And then the remaining level of state level data is another 50% of, if 100% of the data available, we still have about half of the data to go through.
That's right.
And so far, although you had increased rates between Alpha and Bravo, right now it looks like the missile community cancer cohort is not higher than the general population, but that determination at the end is still TBD.
Correct.
Now, with that being said, let's flip it on its head. Just because you may or may not be above the general population doesn't mean that there's not a cancer risk. Yeah, so I mean, you know, you could be completely aligned with the general population and still get cancer. You know, I'm an example number 1, right? So my cancer was number 2 in the top 20 cancers of aviators that the Department of Defense did. But again, that may or may not be a higher percentage of the general population, but that still doesn't negate the risk.
If there's risk.
Right, okay.
Next question, sir. Usually a pregnant member works with public health to report workplace hazards. Has public health changed their recommendation to pregnant members pulling alert as a result of this study?
Good question. I don't think we have, but I'll defer to the experts.
So, sir, what comes down to is what really drives from that OE head of the occupational data exposure list will then be translated into something called a cohort, which effectively is what is being then done and discussed for every single member and employee in that workplace. Part of what we're talking about is for pregnant airmen and guardians, are they additionally at risk? And that information will be derived from the information that we provided here to the individual occupational working groups at the bases, and that determination will be made. At this point, on the examples and the levels and the thresholds that we have measured, I do not foresee pregnancy to be an increased concern based on the values that we found and measured in this current sample and this health risk assessment.
We'll take that one on too, just and tease out that a little bit more for the follow-on.
Thank you, sir. And the last question that we currently have is there going to be a registry of some sort established similar to the burn pit registry for missileers past and present with the VA?
Great question. That would be my objective, but I can't speak for the VA. I think we'll probably, when the study's done, that'll be a discussion with the VA, but I think that's a reasonable, practical thing to do, but I can't obviously speak for the VA. I'm not sure if there's somebody on the VA that wants to answer that question in chat for us, but I don't want to put you on the spot.
It doesn't appear anybody's on, sir. With that, that was the last question, sir. Would you like to offer closing statement?
Yeah, Rick, do you have anything to close out?
No, sir. I think it's been an honor and to really make sure that we are ensuring our airmen and guardians and our missile warriors are in the best place, and that they are cared about, and that they are in a healthy working environment. And so as we iteratively take care of this and get after it, we are here with you.
No, I appreciate it. I can't thank you and your team enough for everything you've done and your predecessor in the last 2 years. And again, complete class act from what you all been doing, and I really appreciate it. Greg?
So we're just continue to work with with all the missile wings and the bioenvironmental and the public health shops to fully communicate, do all the hazardous communication to make sure that everyone understands that their service in that occupational shop is fully documented and that they're being taken care of.
I appreciate it. Again, like we said, if there are questions that you have or do have, or I'm assuming we're posting these slides on the portal, that feel free to send in a question like we have before onto the portal. We'll get those answers out to everybody. I would tell you the level of interest and oversight of this study with the Department of the Air Force and Congress has not waned. I'm very thankful and happy with the interest and actions on the VA's part too. They've been very great partners with addressing this, and I'm assuming they'll continue to be great partners. So again, that wraps up this town hall update for the cancer study, and we'll see you on the next round.